special guest is the Minister of State in the Ministry of Health and Wellness, Dr. the Honorable Sonia Browne. Dr. Browne, thank you so much for joining us.
Thank you, Lisa, for having me.
You're most welcome. Now, as I stated in my introduction, you have specific responsibility for the QEH and for NCDs. Last week, you were in the House of Assembly during the estimates debate, and you touched on several areas at the QEH and indeed your plans to tackle NCDs, and we will expand on those this evening. Now, let's start with the QEH. I want a basic overview of the services offered by the QEH for the benefit of the public.
Okay, the QEH, as you know, institution that was standing since, 1964. They cover a lot of services from way back when. The major ones, to break down these subspecialties would be a little different. But let's start at the ground floor. We offer the accident emergency services, which is, as the word says, accident and emergencies. From there, you go on to the medical services and all the subspecialties attached to that, surgical services and all the subspecialties, obstetrics and gynecology, ophthalmology, ear, nose, and throat, lab services. Now we've added a so-called community outreach program that involves nursing and visiting people on the outside, radiological services, oncological services, and those are the broad areas that the Queen Elizabeth Hospital covers.
The COVID-19 pandemic, that would have caused significant strain on the QEH, with resources, both financial and human, being diverted to care for COVID-19 patients. This also resulted in a significant reduction in your elective surgeries. That came up in the House as well.
That's right.
The Minister, the Honorable Ian Gooding-Edder, would have mentioned cataract surgeries alone. You had a backlog of about 700 people.
It's really more than that. It's really more than that, Lisa. And I must be honest, the ophthalmology surgeries and other surgeries, they were delayed before COVID. It was worsened by COVID. But we found, in walking around the hospital, I found that there are many areas that we can work on. Some are personal areas, which I would not be discussing today, just yet till I get to the bottom of it. But some are small areas which might not require a lot of money to address to get the surgeries expedited. With respect to ophthalmology, the main issue is the cataract removal surgeries. That has been backed up over 800 people, by the way. And these are people that could not afford it otherwise. We have a really well-equipped ophthalmology department. The problem is the Lions Eye Care Center, as you know, has been there for years. We have issues with the roof, and not to fix the roof and do surgeries is counterproductive. We are short on theaters generally in the hospital. They're due for repair. We have issues with respect to delay. Let's get down to the brass tacks, the basic ones. We have a shortage in nurses. COVID helped with that. But we found that there is an exodus of nurses generally to break what they perceive as better waters. As I said, COVID lost a few, and then the specialist nurses have left, and many of them have left. Let me give you an example. In the orthopedic department, we hear every day people complaining that can't get knee replacements, they can't get hip replacements, and so on. We have a lack of specialist nurses in that area. The equipment has now become extremely expensive. The way that they have done it, it has changed over the years, obviously. So the equipment is very expensive. Specialist nurses are absent. Consultants are there. Most of them can do the replacements, for instance. But in a lot of cases, they have to outsource, and who do not have the money will be a little bit of a bind. So we just hired she came in roughly when I came in, Chief Operations Officer. She has a history of bringing a hospital in the US from zero basically to number one in the country. So we're hoping that her expertise comes in here. But we have found that things like surgery starting late are an issue, and that pushes back the whole schedule. You know this. We have found that bookings, they're given to we don't know bookings a week ahead, for instance. We hear about them the day before. So getting theaters outfitting and so on, that's a problem when you have late notice. Then we have to work with the surgeons, actually, to find out what their issues are. And I'm in the process of doing that now. But it's a whole process. Ophthalmology, we have moved on to inviting the Cubans. I don't know if you remember some years ago, Cuban doctors came and got rid of a lot of the backlog. They're about to come again. But for the long run, once we get that backlog sorted, the idea is to fix the roof of the Lions Eye Care Center and the attendant ceilings, getting the equipment we need, because obviously that's a specialty surgery. And cataract surgery is quick, 15 minutes, you're out. So there's no reason we shouldn't keep up on it. People recognize cataract surgery, but there are other surgeries within ophthalmology that are also important that we need to address. So these are delays that have been existed for a while. When I was a student there, that was one of the issues. Yeah, that's dating myself, but I left there 25 years ago. So these are the problems that the general public face. And obviously, if you're in pain or you can't see, cataract is a major cause, a reversible cause of blindness. And if you can't see, it presents a burden not only on the healthcare system, people can't go to work because of illness, it places a burden on the national insurance schemes, other welfare options. So these are the things that we need to address urgently.
And obviously we're talking about elective surgeries, but if you have an emergency case coming, an accident, gunshot injury, stabbing victim, those surgeries are obviously given prominence over an elective surgery. Now, in addition to we would have talked about the cataract backlog, but you have a lot of, and I'm going to be biased here, women who have gynecological issues, so fibroids, etc., who are in a lot of pain and are on a very long waiting list. I know a woman who's been waiting 4 years for this surgery.
Yeah, I know a few from personal experience in my office. This is another issue that needs to be addressed. Again, the backlog here, they're dedicated obstetrics theaters, at least when I used to be there, there still are. But the backlog comes, the COVID, for instance, had to put a damper on that. Staffing, as you know, nurses were sent Harrison's Point, doctors as well in other areas. Polyclinics were a little bit strained. So what would normally be, say, fibroids, sometimes it can be controlled in the primary care setting. When it gets to that point, it really is a burden on women, a real case for morbidity in our female population. And I agree with you, we need to get to the bottom of that as well. It's a very expensive surgery and we need to get to the bottom of that.
You mentioned your community outreach program at the QEH. I don't think a lot of people are aware about it.
Yeah, the Prime Minister, that was her baby, so to speak. Where patients that are discharged, and I would like to see it expanded to include all specialties. People that are discharged from, say, medical wards, cardiac, whatever. We have hired nurses, nursing auxiliaries, to follow them in the community. So that means, and this is really NCDs coming, that means following their blood pressures, ensuring that their blood sugars are normal. So the purpose of this really is to decrease the load on the hospitals. So if we get proper care outside, and it has been shown that the return rate to the hospital is actually less since this program has started. And this is what our goal is. The truth is we need to get to the base of the issues in terms of the NCDs and so on to take the burden off of the tertiary care. In my estimation, and I believe many others, the financial input needs to be, the majority of it needs to be primary care. This is where the prevention comes in, and this is where the early detection comes in. And if you can get under control, and there are many players, we have the Diabetic Association that has been doing a wonderful job in terms of delaying hospitalizations, making sure that for ulcers are healed, making sure that your blood levels are adequate for diabetes, eye care, all that comes in there. So if we could put the focus on the primary care setting more than it is now, it would be helpful.
Now, I'm going to look at the COVID-19 pandemic and the effect it had on the QEH. You had the decanting of the outpatient clinics during the first lockdown. This obviously resulted in increased accident and emergency department visits by outpatients whose appointments were postponed, but their conditions would have worsened as a result of that.
That is true.
What has happened since then?
Since then, well, let me give you the background. I think, like any other good doctor, we start at the base of it with respect to the delay in or the deficiency in care in the primary care setting. As you said, the COVID infections and stuff, pandemic came to the fore. which meant that the nurses in the polyclinics and other personnel were diverted to vaccinations and testing and whatever. So at that point, we found that a lot of the appointments were postponed and postponed and postponed. People did not necessarily have the finances to see a private physician. Hence, your blood sugars, your blood pressure, everything, asthma, whatever, got out of control. There being no place else to go, you go to the next best place, the accident emergency. And that is where the problem came in. The lack of control of these people, of these patients, made it so that the complications associated with said diseases put them there. They required tertiary care setting. In some instances, they used the accident emergency for primary care, which it was not designed to do. So what we have been doing that, and we want to say here quite happily that the polyclinics are open for business. People are still thinking that they're not functioning, they are functioning. And we are welcoming people back into the polyclinic setting. But what we have done, apart from obviously bringing back the polyclinics, because COVID is more or less settling up to today anyway, we'll be diverting back some of the nurses back to where they would be, because the centers, the schools and so on are no longer for COVID people. A lot of the hotels, we've backed off of those. So you have more staff. So more staff will go back into the polyclinics. I'm hoping to get to a point where years ago, probably still now, but not so much, nurses went out into the community and looked after those with the bed sores and the foot ulcers and whatever. So I'm hoping that that can come back. Apart from that, you have the outreach program, as you mentioned before, which we already discussed. That is there to help. But my focus in what I would like to do, we have a NCD commission. I want to see that up and running. Professor Hassel used to chair that at some point, but he has now retired. I want to see that back up and running and functioning. So these are the things that we need to put in place. The National Task Force on Wellness. This is another, I came and found it. This is another initiative that the government did, where the task force concentrates on the outreach in the community, the teaching of educating the public, whether it's through ads, sporting initiatives, working with the schools. All of that is what is happening now. There's the National Nutrition Center, which I will admit it, I had no idea about the National Nutrition Center. But they work with the underprivileged, the children who were affected by COVID, who were undernourished. And the background for NCDs starts there. I dare say from pregnancy till death. So these are interventions that are being put in place. There is, in terms of circulatory problems as a result of diabetes, hypertension, whatever, ultrasounds to see the circulation, those are in place. Unfortunately, the hospital has to outsource a lot of these tests, which in the future I want to see us holding our own in terms of the hospital providing these tests to people. They're expensive, and of course we pay for it. But these are some of the initiatives that we have been putting in place. Things like CT scans, the Maria Holder Trust provided us, they provided us one just to house it now. So that will be on the books going on now. So this is where we are going, the task force, things like that, to start the ball rolling with respect to education in public. So the main focus needs to be on education and data collection. So the UE, university, and so on, we should have been up on this long time as far as I'm concerned with respect to how many people are affected, the reasons that they're affected. Well, we know the predispositions with genetics, but what other reasons? We know about the obesity and the poor dietary habits and the sedentary lifestyles. We need to get this on paper in terms of the numbers, paper figuratively because we're moving on to digitalization, but we need to get the numbers of our population that are seriously affected. I think the last data, and I stand corrected on this, probably was 2018. Some 4 years ago. So we need to be up to date before we can go forward and decide what is happening. The NCD Commission, and Barbados is noted to be forward thinking with respect to NCD prevention and treatment. The NCD Commission, and I want to be a part of this, up close and personal, will be seeking to involve the private sector as well. We have issues, as you know, with sweetened drinks, labeling of packages, which we need. But there's always the pushback from the private sector. But as I was telling one of your colleagues, if we do not start at the base, everybody's affected. So if you have, say for instance, a manufacturer of sweetened drinks, you flood the population with sweetened drinks, diabetes sets in, hypertension, whatever. Your workers are also affected because they use the same things at home. So you have a person calling in sick, depending on NIS, cannot function, so your working day is actually reduced and your productivity is actually reduced. So once we could get the private sector to understand that they play a role in it, the manufacturers, the labelers, as little as the vendors outside the schools, canteens within institutions and schools, once we could get the buy-in from them, quote unquote, it should be easy sailing, but it is not easy sailing because of the pushback that's always attendant. People are thinking about their income. No. Income, how much money will I make this quarter, next quarter, rather than where was my business standing another 10 years if I don't have the people to provide? You heard the Prime Minister, we keep harping on low population numbers. What happens if half of this population is ill and dependent on the ones that are well to feed them, so to speak, monetarily, food, everything. So once we can recognize that the public has to be invested in it, private sector, public as it is, children, adults, parents, grandparents, the church, community groups, once we could get the buy-in from them, it should not be so hard. And I think the awareness of NCDs and the impact, although some of it is out there, we need to push it harder. We need to get it in the school curricula. We need to let it be a conversation within the churches, as I said before. We need basically to have a whole advertising campaign on the dangers of NCDs. I get excited, so my mouth tends to go. On the dangers of NCDs and so on. It has to be a campaign, and it's nothing that can be fixed this year in 6 months. Just like the hospital can't be fixed this year in 6 months. But this is the effort I want to see happening in Barbados.
I want to come back to the NCDs because we strayed a little bit from A&E.
Yes.
You mentioned that people tend to come to A&E because it's the next best thing. However, you have the perennial issue of exceedingly long waiting times. People sometimes at A&E for 2 days without being seen. What is being done?
All right. I want to, let me tell you what the times are like in A&E. Yes, you know and I know that you hear the complaints about the waiting times. But let me tell you what happens in most cases with these waiting times. I went through A&E a couple of days ago. You enter A&E and you are in a triage system, which means they separate the sheep from the goat, so to speak. The more urgent cases from the non-urgent cases. About 15% of those people coming into A&E are urgent cases. They are seen immediately. 15 are urgent cases of what is entering A&E. So you have the heart attacks, you have the pulmonary embolisms, whatever, that need to be addressed now, and there are, right? So that would be category 1, category 2, that are addressed no. Then you have, let's skip a few categories, you have category 5, where these people really don't need an accident emergency service. So there are, in the triage system, they are put on the back burner. So there is where the longest waits are. Category 4, sorry. Category 5 are the ones that have come back for reviews. In between there, you have the non-urgent cases. And when they say non-urgent cases, something that can be fixed with painkillers, say fibroids, for instance, pain, gastroenteritis, whatever. So it's basically a triaging system. So the urgent are seen no, and that, in my investigation, that is down to like a 15-minute wait. Yeah, the hospital, I've seen it for myself, the hospital is aiming at a 10-minute wait. It's where you get to the lower or the higher categories, depending on the numbering, that you see the waits. But when I say that, it is a problem, but I think it can be addressed in that education in the public, they need to understand what belongs to the polyclinic or primary care setting, and what belongs to accident emergency. We're going beyond COVID now. And
so tell me,
pre-COVID.
So tell me what belongs in A&E. Who should go to A&E?
Accident, emergency should go to A&E and review. So accident, car accident, bus accident, emergencies, bar fall at home, broken leg, whatever, gunshot wounds, because we're seeing more of those. Those are emergencies. Then you have the children. Children are always priority, most of the cases. They will come in with the asthma hits, and the pediatric department liaises very well with the accident and emergency. The non-accident emergency cases, people have shown up to the A&E, and I know this from before, with coughs and colds. This is why the fast track was put in place. But we have issues with that, which we will get to. People need to recognize that things like cough and colds really don't belong in the accident emergency. So the delay goes there, because they will wait. More important cases will go ahead of time. And I'm not necessarily defending it because I know the wait is ridiculous sometimes. But the non-urgent cases, coughs and colds, people go there for some strange reasons. Arthritic pains that could be addressed in the primary care setting.
Let me play devil's advocate. You said cough and cold. So I have a flu, a bad fever that is not breaking. I can't come to A&E.
Did you see your primary care physician?
Not accessible at that time of the night.
In the night? And you feel like your chest is bad?
Correct.
Right. You go to A&E, and that's where the triage system comes in. So you want trained persons to be at the triage desk. And nurses are there, trained nurses, more are being trained. So they tend to, they have the ability to listen to your chest. We want it such that we are doing a program with nurse practitioners. Nurse practitioners are just under medical practitioners. They can do a lot that doctors can do. So nurses are getting ready to go for training. We have one there already. So in the ideal world, you can see a nurse practitioner, a trained nurse, even a doctor to decide, all right, Lisa has a cough and cold, chest clear. Maybe she can go home, write the script quick, and let you go home. That's the ideal world. This is what I want to see. Without an adequate triage system, you're going to see faults there.
And long waits.
Pardon?
And long waits.
And long waits. So if we could get the triage system right, the polyclinics are up and running. The 24-hour fast track is still there. So in the middle of the night, you can't access another fast track is there. The problem with that is if you have to get a chest X-ray and so on, you're back at A&E. So these are things we need to address in the polyclinic system, where they need to be outfitted at the very minimum with X-ray equipment, so that Lisa comes in with a cough and cold, I can have a look at your chest. I know there's no pneumonia. You don't need hospitalization. Give you some medication. Lisa comes in with vomiting, abdominal pain. Somebody could be at the polyclinic one of the 24 hours to do a quick ultrasound. All right, her appendix is okay. Painkillers, some Gravol, you go home. So a lot of the issues is that patients are desperate. And when you sit, you're feeling desperate. What might just be a niggle to me could be severe pain and you think you're going to die. Right? So the triage system comes in there. But I agree with you, the waits. The COVID situation, though, has led the doctors, some doctors were put into Harrison's Point and other areas that we open. We should see a return to those shortly. So the staff, and the truth is we are short. Her staff in almost, if not every area in the Queen Elizabeth Hospital. Mainly because of COVID, to some extent because of people leaving the hospital. Many doctors have left for private practices. Physicians are stressed out and burnt out. The population don't ever think that doctors can get stressed. COVID was a source of stress for our staffing at the hospital. But I will not deny you, you're right, we need to get the numbers sped up. But at the same time, and the other delay, let me tell you what the other delay is that I'm seeing. So you come into triage, you are seen by a nurse, you are sent somewhere, maybe they put up a drip of medication, blood tests. No, we do blood tests. The A&E is not equipped to do all of it. They have a machine, but it's more costly to do, you can't do everybody in that machine, so rely on lab services elsewhere in the hospital. Some patients are waiting on the lab services. So while you think, oh, I'm here waiting for 6 hours, you're actually being attended to, but we're waiting on test results. This is where communication with the patient, whether it be through patient advocates, nursing, doctors, whatever, is important. No, we wait on the lab results, and that has been a source of delay too. During the COVID, not even during the COVID, now as it stands, all the labs from the polyclinics are diverted to the QEH laboratories for testing. So what used to be done at Winston Scott Polyclinic, all of these have been diverted to the hospital. So where a hospital would mainly be inpatient, inpatient, outpatient, A&E, we now add 9 polyclinics to that mix. So the delay is there. So what we need to do is to get some of that testing away from QEH. So the patient waits for blood test results, that's another delay. A&E, the CT scan, if it's not working upstairs, we don't have one put in place yet, that's another delay. So while you are there waiting, it's not that nothing, in some cases, I'm not going to say all, I'm not going to indict myself that way, because the wait is real. But some people, because the patient advocacy needs to be a little stronger, communication between the doctors, you get a lot of complaints, and most of the time the complaints are with respect to attitudes. You know this, you're shaking your head. Respect to attitudes of the staff. So these are areas with respect to human resources that we need to address. One of the major things that needs to happen is that we be able to treat our staff for stresses and psychiatric issues. We are people too. So if you have a doctor that's overworked, double shifting, whatever, you don't like it, but sometimes that comes out on the patient. By the same tokens, there are some patients that are just unreasonable. We have had instances in the polyclinic, and they think, yeah, hospital setting where doctors and nurses were attacked by patients that also got irritated and so on. These are things that stress out staff. And we need to look at systems where there's some place for the staff to go to deal with the psychological issues that we are facing now. So while there are delays, I think one of my missions is to see that shorten the time span between door to discharge or door to admissions. The other delay, Lisa, and the public needs to know too, is the bed space. And not saying shortage of beds, but sometimes we have a whole, a lot of them were moved, but recently we have had up to 25 elderly patients for care. So these are people that were either left at the Queen Elizabeth Hospital and nobody came back. So they're not ill, but we have to put them someplace. So, and I don't necessarily blame families for this. The first thing people say is the families to blame, but some people can't do any better. You have a son looking after a mother that is bedridden in diapers, has to leave work to change, has to leave work to make sure she didn't fall off the bed. Some people just can't do any better, and private care is expensive. $2,000-$3,000 a month, that's some people's salary. So we had that backlog of elderly for care there, no place to put them. We are putting measures in place now where one of the outpatient clinics, St. Lucie District Hospital, not outpatient, District Hospital, will now be converted hopefully to look after those elderly people coming from the hospital to there. So that would be a good thing to happen. So beds will open up, so they delay downstairs. Some people are in A&E for 2 days being treated because no bed space, but they have started a bed management department, and this is a department dedicated to going around the wards, seeing who needs discharge, who can be discharged, so that beds are free, and that has been working quite well. So it's all right to say that there's long delays, but I'm giving you some of the reasons for the delays. The trick now is to fix the reasons for these delays.
I want to continue talking about these delays, Dr. Browne, but we'll take a break here. You're watching One on One. Hi, I'm Caroline Gittins, a quarantine officer with the Veterinary Services Department of the Ministry of Agriculture. There's a disease called African swine fever that is affecting domestic and wild pigs worldwide. Even though it is not harmful to humans, it has the potential to wipe out every pig in Barbados. If you or your family members are traveling to Barbados, apply for a meat permit from the Veterinary Services Department. This permit tells you if it is safe to bring pork products from the country that you intend to travel to. Purchase products only in their original packaging that are clearly labeled with the inspection stamp. That means no bacon or sausages from the deli in the supermarket or from a butcher's shop. Do not cook it, since the disease can survive high temperatures. When you reach Barbados, we ask that you declare all your meat products to the customs officer. We need your help in keeping Barbados safe from African swine fever. And welcome back. Dr. Browne, before the break, we were talking about delays, but one of the issues people have in terms of delays is a delay for an ambulance to call, and there seem to be none available most of the time.
Okay. Well, yeah, expected the question, so to speak. Yes. I have experienced it myself as a GP on the outside. You call an ambulance, and a lot of the times you have to bring in the private ambulances. Right now, the ambulance service has a fleet of 8 ambulances. We are expecting donations, at least 2, over time, over a 3-year period, I think, stand corrected on that, where 2 will be donated to the ambulance service. Now, the idea behind the ambulance service is not to have, you have 8, but at some point 2 or 3 will need servicing, right? And they need servicing often because they're on the road a lot of the times. So then that takes maybe 2 out of the fleet, so call it 6. The response times I have noticed have been a bit better this time lately. They're now in Wildy for now at least, and that seems to be a better area, almost decentralized, so that it can reach almost every area. On my visit to the ambulance service, they are able to now track where the ambulances are for more efficiency. So if I know an ambulance is somewhere in St. Philip and somebody from St. Philip calls, you pick the one that's closest to go. They can know they can know look at traffic patterns, for instance, to have ambulances get to where they need to go quicker. These are some of the things that are happening. But we need to increase the fleet so that you have time for ambulances to be serviced while they're still on the road. We need to get a little more modernized in terms of, and this is all ambulance, not necessarily times yet, more modernized within the ambulance service where it becomes a little more digital. We still have a book system where when somebody calls in chest pain or whatever emergency, if they don't know it, you flip through a book. These things need to be digitized, right? We have well-trained staff, but the hope is to integrate, and I hope I'm not speaking out of turn, but the whole aim is to integrate, for instance, the fire service, and we have trained officers in there who can assist with the ambulances. The fire service and other players, the Red Cross, all of these are players that we need to incorporate. So the hope is once we get the fleet increased, and you can't bring in 5 ambulances one time because they decay at the same time. So over the next few years, I think there are plans in there in the capital expenditure. That's not my area in terms of finance. But where we can increase the fleet ever so often so that you always have well-working ambulances. So the delay really, what delay is now can be blamed on that, as well as, and I'll tell you the one that you may not expect. So ambulances pick up a patient and they go to the hospital. And this is where the delay happens, go to A&E. They go with their beds, their gurneys. But if a bed is not available, patients stay on the gurneys. So that is a gurney that is taking up space that cannot be back out on the road. So because no beds are available upstairs, it trickle down. So if there are no beds upstairs so that you could get a patient onto the ward, the patient that belongs to the ward stays on that bed. So the patient from the ambulance cannot get on that bed because of the delay further up. So it's not so much that the ambulances are delayed because of bad practice, but a lot of the strain comes when they hit the hospital and you cannot get the patients moving. So that ambulance cannot get back out on the roads to service other clients. So that's one of the issues, but we're hoping to get that sorted out. And I think it's something that can happen. Once we could get the hospital back up and running properly, the bed management does what they do to the best that they can, because other factors come in there too. We should see a little help on that. But generally, I have noticed an improvement in terms of the pickup from ambulances, the response time. I have noticed that they're even more equipped now in terms of technology, the ability to, the equipment in there to address cardiac arrest, those kind of things. The training is top notch and the training is continuing. So I'm hoping that we could see more improvements. There have been some improvements, I can't deny it. But I'm hoping to see that it runs a little more efficiently, but we have people there that are willing and able to do that job.
You have responsibility as well now for chronic non-communicable diseases. You touched on that briefly, but a lot of the pressure placed on the QEH is as a direct result of NCDs. As a medical doctor, what are you seeing, or what were you seeing in your private practice?
With respect to NCDs, the ones everybody know, the diabetes, the hypertension. Cancer is always an issue, and people never remember cancer as an NCD. So cancer is another issue. We're seeing breast cancers. Me, personally, more breast cancers, and I think those numbers are increasing every year. Speaking with the surgeons that I know, those numbers are increasing every year for breast cancers, but hypertension and diabetes are big things. So that being said, things like hypertension and diabetes lead to bigger things: stroke, heart attacks, peripheral vascular disease. All of these things go from there, but in terms of NCDs, those are my 3 top that I see.
If you had to pick out one as the most prevalent.
That I see, I would say hypertension and diabetes almost rival one another.
In most instances, is it hereditary or is it as a result of our lifestyles?
Lifestyle.
Really?
Yeah, lifestyle, a bit of both, hereditary, in that order. So obesity obviously is a problem, and this is from small toddler stage up. We're seeing a lot of the children below 5, teenagers that are obese. It only takes a trip to town or to fast food place and you will see they are overweight. So it starts there. I've always been taught that an obese child, toddler, is more difficult to lose weight as an adult if you were a fat child. So the crux of the matter is to begin begin in pregnancy, to be honest. We need to teach mothers how to take care of themselves. Hence the baby. When this baby is born, you need to advocate breastfeeding. Breastfeeding is known, unless if for whatever reason you can't do it, and there are reasons. Breastfeeding is known to keep your weight down, good for brain development, keeping you healthy generally. You know this, Lisa. You're shaking your head, you know. So start from that area, right? In terms of nutrition. Is the primary care physician, including the polyclinics. This is what I mean. There's primary care setting for gynecologists too. They work primary care for all intents and purposes. That's primary care too, in terms of preventative and following an antenatal patient. So this is where we need to start, with the mother and the father, because they're supposed to be a part of it. So we get the baby nutrition down pat, and there's no lack of, other than breastfeeding, if you can't breastfeed, there's no lack of good baby formula out there, so start there. You enter school, before school, child starts eating. The only way a child knows about sugar is because we feed them sugar, you know. You hear the old adage that the doctor stopped me from using a lot of sugar, but I need sugar, my body needs sugar from where? Carbohydrates turn into sugar. You eat a potato, it's sugar. You eat, unfortunately, the macaroni pie and flour, it goes into sugar. The only reason we know about sugar, processed sugar, is because we were fed as babies. Because some mothers still give a little sugar water. Some mothers feel the need to do that. Some mothers taste the formula and figure ain't got enough sugar, so they add it in. These things actually happen. So start there. But it's all right to say, mother, I am getting my child to eat fruits. I'm trying to get my child to eat vegetables. But ask the parent if they do it. Do as I say, but not as I do. So it needs to start in the home before we even talk about school. You have people that are maybe the only hypertensive in the family, but they cook 2 pots. My family can't eat the low salt diet, so I'm cooking for them and I'm cooking for me. Start at the base. Everybody can't eat the same thing. If they don't know it, they learn to know it. You can get used to anything. You go into prison, you get used to prison. You can get used to a low salt diet. You can get used to a low sugar diet. So this is where it needs to start. You enter school. A lot of mothers say you need a snack. But what is the snack? The snack is hardly ever fruit. But some schools have been doing well on this, though. They might put aside a fruit day.
Yes.
But every day is a fruit day in my world. Every day is a fruit day. Every day is a vegetable day. We need to, yes, you have to have a fruit day, but why not a fruit week?
Because fruits and vegetables are expensive. That's what they will tell you.
Grow your own fruits.
Where am I growing it? I don't have the land to grow it.
Everybody has land to grow a fruit. Or a neighbor that has fruits. How many mangoes you pick from a neighbor's tree? You don't want mangoes and diabetes, but you get what I mean. Get the drive on. Agriculture needs to start working on that. And this is where, and I veer off again, this is where all the ministries need to come in. So you start there at the base, you enter school, do something about the vendors. The vendors work beautifully outside school. You have to educate the vendors. If there's nothing else to offer, children will eat it. If they're seeing the teachers eating fruits, they follow. There's nothing like a teacher in a child's world. You could tell a child the sky is blue if a teacher says the sky is purple. They believe it.
Correct.
Start there, educate the teachers. And because they're teachers, they don't know everything. Just like I don't know everything. Educate the teachers on what is good eating. Educate the school meal servers on what is good eating. Start there, educate the vendors. Get the cafeterias, and this is mostly secondary schools. Children buy chips and chicken or only chips every day for lunch.
Yep. That was
Fried
happening from
chips.
my time. Yeah.
Exactly. Start making it policy in schools. And we don't need governmental policy here. Get your cafeteria contracts, have them agree that their diets will be well-rounded, right? Vegetables, fruits, low sugar drinks or no sugar drinks, offer water. These are things, this is where we need to tackle. And this is primary up to secondary school. Offer scholarships. We can do things like that. Offer scholarships in food and nutrition. Let people study it and come back. It's two things that are going to be very important in the future. Agriculture, in terms of food supply, and education about diet and foods. These will go hand in hand. Offer things like that. Offer schools, do schools competitions where schools can benefit from having just like we do the Go Green or whatever in the hotels, and they get awards. Healthy eating in schools, let it be taught in Sunday schools and churches. Bring in people in your church to speak about the proper diet. It's funny, most of the people that I have seen as diabetics are anxious to see a dietitian. They don't listen to me. They want to see a dietitian. So put dietitians at strategic points. Put a dietitian in every polyclinic. I'm not sure if there are. In my time, I think they had. And put dietitians in every polyclinic. Use the posters to drive it in people's head. Put the ads on television, and I've seen some. Your colleague had No Sugar November?
Shane Jones, yeah.
What happened to January, February, March, etc.? Right? Put measures in place where people have space to exercise. I spoke about this in Parliament the other day. I was asking, how come roads are being built and no sidewalks? We have our no bicycle lanes. The answer was a little weird, but anyhow, people want to walk. You remember when COVID got locked down, we were given the curfew hours? Mm-hmm. People were walking like crazy. People were riding. Everybody had a bicycle. Make that so. In other words, do proper hiking trails. Put sidewalks on the roads where people can walk in safety without fear of being run over by a car. You're scotching on the side of the road. Make the parks, and a lot of them are doing that now. I see little areas where you can actually do dedicated exercises. Encourage that. COVID is opening, is decreasing now. The world is opening up. So there's no real excuse for us not to do it. Teach people how to exercise from chairs. There are people that can't walk. There are exercises, YouTube it. You can exercise quite efficiently from your seat without having to walk around. Promote things like dancing, that's exercise. Promote things like gardening. You just spoke about you not have any space for fruit trees. But I bet you have planters that you could grow your own vegetables, right? Make it a neighborhood effort. Let it be that we pass houses or communities can do a little kitchen garden type thing for themselves. There are things you can do. There are things you can do to promote healthy eating and healthy exercise and those kind of things. Just like how we put a ban on advertising, what was it, cigarettes? Put a ban on, we're going to get some pushback, but put a ban on advertising in terms of processed foods and so on. That one would be a little more difficult. Work with the drink producers and the people that do the flavored milks, wherever overseas or here. If they can cut it out, at least decrease it. When you see 16 grams of sugar on a bottle, this is what? 4 teaspoons in a drink. If they could come down 2 teaspoons, and Barbadians get into the habit of their taste buds get used to a low, if you want to stop me, feel free, to a low sugar diet, we can fall in line. It's just a matter of getting accustomed to. So you start at the Monday, you get into school, you get into secondary school, you talk about education. So there's the areas, this would bring a big burden off of the secondary tertiary care. Because if those people do not get hold of hand, if those people are controlled, prevented from getting the NCD, for instance, if they do get it, keep it under control, it decreases the burden on the tertiary care setting.
Are we still known as the amputation capital of the world?
Yeah, we're still fairly high up there. People still say it, and it's real. Measures put in place to do it. There's access now to, let me go back, amputations, usually due to poor circulation, whether it be a cause from diabetes or what have you. We have now Barbados. I'm not necessarily speaking about governmental, but there's access to ultrasounds to see what's happening with circulation, access to angiography to see if there are any blockages anywhere, exercise for poor circulation, that helps. There are things that we can do before that happens. Even when after it happens, there are ways you can open up the circulation to get ulcers to heal and so on. So, but these are some of the factors that have contributed to us being known as the amputation capital. So when diabetes get out of control, people are not educated on the type of shoes to wear. Let me give you an example. I had a diabetic. I work well with examples. And he came to me with something on his foot, I forget. But in dealing with what this something was, there was a thumbtack in his foot. It wasn't bleeding, so I had to be there for days, and he was unaware of it. Because not only the circulation, but his nerves were affected by diabetes. So people need to be educated what shoes to wear shoes in the house, how to cream your feet, not between, little things like that. It sounds little, but they're big.
But there's a complaint as well that doctors are too quick to do amputations. Yeah.
I can't agree. I really can't. The truth is we try our best. I'm not going to tell you there are instances where people refuse to amputate and they were fine. But a lot of the times, if gangrene sets in, you really have no choice. Amputate or death. But people say doctors are quick to amputate, but this is the cases we see. We have a very high population of diabetics and hypertensive diabetics. Diabetes is probably the biggest issue here with respect to amputation. Cuts that go awry, people that got a little bruise that they stay home because they're scared to go to A&E or they're scared to go to the doctor because their foot will get cut off. So sometimes if you could address these issues early, it does a lot with respect to prevention.
You mentioned diabetes, hypertension, poor circulation, the popular ones. But one that is very concerning is high cholesterol, and we don't hear a lot about that.
High cholesterol. You're right, and thanks for telling me that. We need to hear a lot about it, and it is around us. Well, you know, high cholesterol, in easy terms, block up your artery, stroke, heart attack, bad circulation, that kind of thing. Yeah, that has to be pushed a little more, a lot more, really. But by the same token, once we push it enough, we educate the public on what contains high cholesterol. And unfortunately, we have a lot of fast food outlets that the cholesterol meccas in Barbados. And a lot of them are being set up right by schools. Right by schools. I've watched children leave school and go straight into fast food establishments. And that is really high cholesterol is. People love eggs, Bajans love eggs. Anything related to chicken, we love. High cholesterol. And most of the time, nobody's telling you stop eating eggs. Moderation is the key in a lot of cases, but you are right. Cholesterol needs to be at the forefront in terms of control. People are aware of it from if they go to the doctor and we do our routine examinations, but people are not mindful in terms of when they eat it. You're right. As you said, they think about the sugar and they think about the salt, but nobody remembers the high cholesterol. So this is another conversation when they have on my doctor hat. But you are right, and I will put that in the front of my brain to start working on in terms of education, cholesterol, and having a conversation about high cholesterol levels.
And something that is very high, and I don't think the average Barbadian appreciates it as much, the high cost of healthcare. Do we need to move to a system where we look at the whole concept of Barbadians really going forward and getting medical insurance?
I think so. This is a big issue. The biggest, of course, is the cost of the medical insurance, right? cost of medical insurance, and people think they never get sick. Young 25-year-olds never think they get sick and die. So the message, and I will put this on the insurance companies, make health insurance affordable. Right now, and I guess this is across the world, we have a rating system where you are rated if you're diabetic. There are some diabetics that are diabetic before they start working, but they're rated, so they don't want to give them health insurance. Although there are other diseases out there, so we need to make it a little more accessible to the general public in terms of costs and the ratings. A lot of people can't afford. The average health insurance is what, $300, $400 a month?
Just under.
Not for me. Anyway, per month, just under that for a month. All families can't afford it, especially since COVID has hit. A lot of people are still home, not working, unfortunately. So we need to find a way, let it be a group health, let it be offered. This is coming out of my head suddenly now. Let it be offered to groups, community groups, for instance. So BARP, retired persons, they have their
They've reduced,
plan.
yeah, and they've reduced the age now to 40.
I don't know why to call it retired. I would love to be in that category. But anyway, but involve associations like that where people can have access. Let it be community groups so that the cost is less. And that would take working with the insurance companies and getting the message out there that health insurance is important. This is one of the reasons as well that the hospital is so indebted. One reason is people don't have insurance, so we have to use the government coffers to access that. Two, the people with insurance don't admit it, don't reveal it. Because by rights, the hospital can be included in terms of getting insurance reimbursements, but people don't reveal it. Just like medication, by rights, people with insurance should be using their insurance to pay for medication on formulary, but that doesn't happen for fear of being charged more or whatever. So we need to make that a system, make it a part of the patient information, make it a part of that, but the question is, how do you get it out of the patient in terms of admitting that they have health insurance? But the insurance companies need to step forward here and recognize that it's an important step. You really can't do much in the States without health insurance. And we have done a lot in terms of outfitting the public with free medication, free doctor's visits. I think some of the public can do their part in terms of this too. But accessibility is the key word here.
And at the end of your tenure as Minister of State, what would be your number one goal that you said, okay, yes, I achieved this?
The waiting times is one. I would like to see the surgeries back up and running. I would like to see the hospital get back to an institution where we incorporate private patients. The hospital, yes, is a governmental free institution, but we need to make money. We need to not always rely on the government coffers to outfit the hospital with certain things. I would like to see that happening. One of the banes of my existence is the availability of services in terms of radiological services. We would love to have a MRI, magnetic resonance imaging machine. And people think that's brain and tumors and stuff, but it involves every department. Everybody can benefit from that. So these are things that people, we need. Those are the main ones. Of course, there are a gazillion things I would like to see fixed. But once I could see, with respect to the hospital, these things happening, but outside of the hospital, I would like to see more emphasis placed on primary care. We do well. The truth is we do well with respect to screening. We talk about cancers, cervical or cervical cancers in females. The government has been offering HPV vaccines for a few years now, way before me, a few years now, and that's a preventative measure. We have a beautiful lab that I just visited, Best of Santos, but people associate it with COVID. Mm-hmm. But they have a lot of services. So I would like to see more emphasis and funding placed on the primary care setting, whether it be public or private. We need to get that done. The only way you could get the burden off of the hospital, the only way, is to have the primary care setting supported. we need the financial support, we need the advertising, the polyclinics too. We need to be outfitted properly to take the burden. We have St. John Polyclinic, the David Thompson Polyclinic, and that was slated to be a 24-hour, and I veer off here, 24-hour clinic, but we need the resources in there to make it so, whether it be staff or equipment. These are things that would bring a great burden. So if you could get that burden off of the hospital, I am sure you can see the hospital functioning and become the great institution that it was when we were so well respected internationally and regionally. Those are my main ones.
Dr. Browne, thank you so much for talking to us. It really was a pleasure. That was Dr. Sonia Browne, the Minister of State in the Ministry of Health and Wellness. I am Lisa Lord. Thank you so much for watching One on One. Good evening.